Okay, so welcome to my service improvement proposal. It's introducing debriefing sessions for ICU staff after traumatic events. Next slide, please. The area that I'd like to improve is the psychological wellbeing of staff, and here is the Intensive Care Society's definition of staff wellbeing, and this was taken from their staff wellbeing framework. Next slide, please. This presentation is a service improvement proposal for my intensive care unit, and the service I'm proposing to improve is staff wellbeing in the division of resilience and human factors, which is listed in the permitted topics within the assignment brief. I'll discuss the importance of improving staff wellbeing, and using local evidence, I'll demonstrate the need for improvement. I'll be proposing the introduction of a new practice, which is a permitted activity within the assignment brief. And the proposed practice will be debriefing post-traumatic event, and I'll discuss how debriefing will improve the psychological wellbeing of ICU staff and critique the contemporary evidence on this topic. The PDSA cycle will be used as a change implementation tool, and I'll be evaluating that as well as acknowledging some of the complexities of service improvement itself. Next slide, please. So why is this relevant for ICU? Well, working in ICU is widely recognised as a uniquely demanding occupation. This is due to a combination of the high stress environment and the traumatic nature of regularly being there and witnessing critical illness and patient death. Repeated exposure to this high stress and high stakes environment has serious consequences on the well-being of staff, and as a consequence, burnout in ICU staff is significantly high due to witnessing these events. The rate of turnover for ICU nurses is up to double the rate of other clinicians, and we know that 56% of nurses leaving the profession do so due to high levels of stress. Clinical errors and suboptimal care are also more likely to occur when stress levels are higher, and high staff turnover, as I previously mentioned, is also a consequence of high stress levels, and keeping the service well staffed is already a huge challenge for the NHS. Next slide, please. So what happens when staff wellbeing is improved? Well, evidence shows that health services become more efficient and better staffed, mortality rates drop, and patient satisfaction increases. Next slide, please. To evaluate the staff wellbeing in my trust, I've collated qualitative data from the NHS staff survey from 2020, and it showed a significant drop in psychological wellbeing, staff morale and engagement. In addition, there's an increase in staff being unwell due to work-related stress and coming to work despite feeling unwell, and an increasing number of staff are planning to leave the trust. I decided to use the survey because the results are generated purely by the staff of the NHS, and a section of this survey is specifically aimed at measuring well-being. The report is generated with significance testing and automatic benchmarking against similar-sized acute trusts. Next slide, please. I've also included quantitative data by obtaining the staff turnover percentage, which is 3 times the number we're aiming for. It's not possible for me to attribute this to any particular reason, as the staff weren't asked prior to leaving, but I did feel it was important to include this because contemporary research shows that there's a significant correlation between high levels of stress and high staff turnover. Next slide, please. So I've anonymised these pages of the staff survey report. The page on the left shows the organisation details, the response rate and the size of the trust. The response rate of my trust is slightly higher than average, but it's not a complete survey of all staff. So you could argue that the data isn't quite comprehensive enough, but the information is, the survey is produced specifically to highlight areas that may need development. So I feel that the data collated by this survey is exceptionally relevant to this proposal. The page on the right shows the statistical significance of the survey results. Next slide, please. So the wellbeing results in the staff survey for the trust were so concerning that the trust has initiated a campaign for staff to develop improvement proposals. This wasn't released when I did my first sit of this presentation, and so the trust has publicly responded to this information since then. So the image on the left is displayed on the staff intranet. You can see the staff survey is referenced multiple times, and staff wellbeing is the #1 agenda that the Trust agrees does need improvement. The image on the right is a poster that the Trust have displayed around the hospital and in staff areas, which contains the same message. Next slide, please. So what is a debrief? For the purposes of this proposal, I define a debrief as an informal meeting of staff who gather together as a group to discuss the emotional impact of the event that's triggered this debrief. It's similar to a Schwartz round in that the focus is on the emotional needs of the staff and offering reassurance and support as needed. Staff will leave the clinical area to debrief, and their patients' care will be managed via the buddy system, which is the practice that we currently utilise for break relief and for family meetings. The debrief will be led by a member of the clinical team, usually the consultant or nurse in charge. However, debriefing training is currently offered by my trust, so anyone with this training would be able to lead. Next slide, please. So why do I think that debriefing will make a difference? Well, there's a huge amount of evidence to show that debriefing is beneficial to healthcare staff, and these benefits also extend to our patients. Debriefing is especially valuable to ICU staff, and it's recommended by the Intensive Care Society. These benefits include team connectedness, which is an area that my trust says needs development, and individuals report huge benefits to their emotional health and ability to cope with stress. Following cardiac arrest or unexpected patient death, debriefing has been found to offer emotional reassurance and support to staff. Ultimately, debriefing leads to improved staff well-being, and this results in better patient care. The last point on this slide regarding debriefing not being offered enough was reported in a study that was conducted in a cardiac ward regarding the efficacy of debriefing post-cardiac arrests. So you could argue that perhaps this study isn't relevant to ICU, but the topic and the subject of the study is relevant to this proposal. And actually, it may even indicate that if successful, the service improvement could even be adopted by other departments. Next slide, please. In my unit, our debriefing practice is almost nil. An audit was performed due to the increased number of emergencies on the unit as a result of COVID-19 in 2020, and just one debrief had taken place within the previous year. Only 40% of staff took part in the audit. However, most respondents were Band 5, and Band 5s make up the majority of staff on our unit, and they are consistently patient-facing. So I argue that the audit is objectively relevant to this topic. The one debrief that did take place was reportedly a helpful and positive experience by those who took part, and all respondents to the audit indicated that they would like to take part in regular debriefs. As you can see, debriefing after cardiac arrests, invasive procedures and other high-stress events is widely recommended in the guidance from multiple reputable sources. Next slide, please. Initially, my aim would be to introduce 3 events that would be routinely debriefed. These would be all cardiac arrests, all emergency intubations, and unexpected or difficult patient deaths. And the rationale for choosing these 3 events is because evidence shows that these events cause the most stress and PTSD in ICU staff. Although the majority of research finds debriefing to be beneficial, there's not all individuals may benefit from debriefing directly after an event, and there could be reluctance to discuss feelings and emotions from some individuals. So it's important to clarify that debriefing will be voluntary, not mandatory, and if an individual doesn't feel able to attend a debrief, it's essential that they're not forced. The daily nurse in charge forms will be used to initiate the debrief in a timely manner, and they'll be used to record the number of debriefs that have taken place. And they'll include documentation on who attended and who declined. And in the event that a member of staff does decline, their line manager will be able to follow them up and see if they require support. Next slide, please. I chose the PDSA cycle as the service improvement tool for this proposal because it's successfully used already nationally and internationally to change and improve practice. It's suited to making simple changes in one department, which is ideal for my proposal. One of the main principles of the PDSA is to initiate change with a primary cycle and then build on or refine the change with subsequent cycles. which will allow me to continue to revise the change if needed. It can be considered quite a simplistic tool. However, simpler tools tend to empower frontline staff to take on the complexities of service improvement, and that is the reason that I was drawn to it initially. After ascertaining the need for change, the PDSA asks 3 questions. What are we trying to accomplish? Well, we're trying to improve staff wellbeing. How will we know that the change is an improvement? Well, data collection and analysis following the change, both quantitative and qualitative. And the final question, what change can be made that will result in an improvement? The implementation of debriefing for staff following traumatic events. Next slide, please. So I developed some SMART aims to focus my proposal, which is recommended to ensure that goals are specific and articulated clearly. My SMART aims are for MDT debriefing to occur within 48 hours for at least 60% of relevant events, as evidenced by the nurse in charge documentation using an appropriate reflective framework, within 3 months of implementing the debrief policy. I would obviously prefer for 100% of incidents to be debriefed, but considering that our current rate is 0, I felt that 60% was a more realistic goal. And at this stage of the proposal, I'm not recommending the use of a specific reflective framework. There are many tools available, and it's important to use one that suits the team and suits the situation. And the nurse in charge documentation will be used to ascertain if this aim is achieved in the given timeframe. Next slide, please. So to ensure the best chance of success, the PDSA cycle will be used in full. The first stage is plan, which involves defining the change and planning data collection. So you can see that the plan change is to introduce debriefing sessions for ICU staff following one of the specified events. The plan data collection includes qualitative data from the staff survey and quantitative data in the staff turnover. However, this data collection could take up to a year. So allowing staff to feedback regarding the efficacy of debriefing in the meantime is essential. This feedback can be formal or informal using the existing communication methods already in place within the unit. Next slide, please. The next stage of the cycle is do, which includes the implementation of the new practice and effective communication of the change to staff. Communication of the change will be via a variety of methods, including email, instant messaging, posters, start of shift, briefing, and regular reminders. Data collection will also begin at this stage, and although it's quite early for the staff survey results, turnover and feedback data can start being collected. Next slide, please. Okay, the study stage, this is where the data analysis is completed and compared, and comparisons will be made between the collected data and the previous data, and also the predictions made at the beginning of the change. So my predictions for this change will be that the well-being of staff will improve and staff turnover will decrease. And the data analysis will also establish any adjustments that need to be made. Next slide, please. So finally, ACT. Which will involve planning the next cycle to introduce any adjustments needed and potentially refining the change further. For example, I could expand the number of events that trigger a debrief, which may be beneficial for staff. Next slide, please. So it's important to consider resistance to change, and unfortunately not all plan changes succeed. The majority actually fail due to change resistance. So it's important for me to try and anticipate and reduce potential resistance early on. According to Hariram, there are 3 types of resistance to consider: intellectual, personal, and cultural. So for my proposal, the cultural resistance may be that senior management are reluctant for staff to leave the clinical area due to patient safety concerns, and there may also be a perceived lack of time to debrief. Personal resistance may include a hesitancy to engage in what can be an emotional...
You got 2 more minutes.
Okay. And intellectual resistance may be caused by staff not understanding why debriefing is relevant for them. An important consideration, next slide. A really important consideration is leadership styles on who may lead the change. Transformational leadership style is considered to be the most effective, and that's thought to be because transformational leaders lead from the front and inspire their staff to follow. However, change resistance is not always due to a lack of inspiration. And transactional leadership could also be considered, as it builds trusting, dependable relationships. However, transformational leadership is especially suited to leading change, and it would be the beneficial style of leadership to enact this service improvement. It may also be beneficial to have link nurses or doctors. So implementing change and managing resistance cannot be achieved by myself alone. It's crucial to identify and engage potential stakeholders early on in the process, which may be the deciding factor in success or failure. Next slide. So to do so, I identified my managerial stakeholders and the wider stakeholders, as the influence they each have on the department varies in different ways. My managerial stakeholders are the ICU matrons, consultants, and senior doctors and nurses. And the wider stakeholders are the Band 5, 6 and nurses, and although and the rest of the MDT and rotational doctors. And although they have less managerial influence, they are ultimately the key to ensuring that this change becomes standard practice. Next slide. The managerial stakeholders' acceptance of this change may be influenced by patient safety, staff wellbeing, and the retention of their staff. So reassuring them that patient safety will not be compromised and providing evidence of benefits to staff may ensure this support. And next slide. And wider stakeholders are the rest of the MDT, and to ensure their support, they will be reassured that their duties will be covered by the buddy system, and they'll be given evidence on the benefits of debriefing, and hopefully this will secure their support for this change. Thank you.
Lovely, thank you. Just in time. Okay, just one more thing to say, Crystal, that the results will be available around the 13th of October. If it does become available before that, I'll probably post a message on Blackboard, or I or the hub will send an email to say that the results are out.
Okay, thank you very much.
All right, okay, you're welcome. Take care, bye.
Bye.